Hello and welcome. Let's talk today about digestive system physiology. First here, I'd like to tell you this digestive system is a very fascinating system. You'd probably say that with all the other systems, endocrine system, I said that with cardiovascular, nervous. We'll see here, this is a very good system as well, very nice system. Here, this system is compared to a disassembly line, and we'll check all that out there as well. Now, when we go through, we talk about this system here. Now, when we talk about a healthy digestive system, a healthy digestive system is going to be essential to life. And the reason why it's going to be essential to life is because it's going to convert foods into the raw materials that build and fuel our body's cells. The digestive system, it takes in food, breaks it down into nutrient molecules, absorbs these molecules into the bloodstream, and then rids the body of indigestible remains. Now, when we go through and we talk about the digestive system, here we can go through and we can see the organs that make up the digestive system. These organs of the digestive system, they get divided into two main groups. The first group we'll check out is the alimentary canal, and the second will be the accessory digestive organs. Now, when we talk about the alimentary canal is also called the gastrointestinal tract or the GI tract. Now, this gastrointestinal tract, the GI tract, or the alimentary canal, whatever you'd like to call it, is a continuous muscular digestive tube that winds through the body from the mouth to the anus. It digests food, breaks it down into smaller fragments, absorbs the digested fragments through its lining into the blood. Now, the organs of the alimentary canal are going to include, we can see here first is the mouth, the pharynx next, the esophagus, the stomach, the small intestine, and then the large intestine. So these are all the organs that make up the alimentary canal or the GI tract. Next, then, when we talk about the accessory digestive organs, now these accessory digestive organs are the organs that are going to be hooked up to this alimentary canal. And the accessory digestive organs are the teeth. So it include the teeth, the tongue. So the teeth, the tongue, the gallbladder, and a number of large digestive glands, such as the salivary glands, the liver, and the pancreas. So we'll go through and we'll check all these organs out one by one. First, let's look at the digestive processes. Here we have 6 essential activities, and here these digestive processes we are going to be able to appreciate now from this view as well. Now, the digestive tract, I told you, can be viewed as a disassembly line. Right? Pizza Hut is the assembly line, and here our digestive tract is going to be the disassembly line. Now, this is where food is broken down and its nutrients become available to the body. The processing of food, just sounded like I wasn't saying it right. The processing of food by the digestive system is going to involve six essential activities, basically. First, we have what we call ingestion. Ingestion is speaking of taking food into the digestive tract. Usually, this occurs via the mouth, via the oral cavity. However, this can change in different patients. Sometimes your patients are going to have a feeding tube hooked up to the stomach. Okay, so there then situation can change. So ingestion is number one. Number two is propulsion. Propulsion is a process that pushes food forward. It pushes food forward through the alimentary canal. Now, when we talk propulsion, propulsion is going to include swallowing, which occurs in the oral pharynx and is initiated involuntarily. And is initiated involuntarily. So we said propulsion includes swallowing, and it's also going to include peristalsis. So swallowing, we said, is a voluntary event, and peristalsis, an involuntary process. Peristalsis is the major means of propulsion. It's basically alternating waves of contraction and relaxation of the longitudinal muscles in the organ's walls. The main effect of peristalsis is to squeeze food along the tract, but some mixing occurs too. Peristaltic waves are so powerful that once swallowed, food and fluids will reach your stomach even if you stand on your head. Next then we have, when we talk swallowing, it takes place in the oropharynx. When we talk peristalsis, you can see it takes place in the esophagus, in the stomach, the small intestine, and also the large intestine. Next then let's move to mechanical breakdown. Now, when we talk about mechanical breakdown is a process that increases the surface area of ingested food, physically preparing this food for digestion by enzymes. Mechanical processes will include chewing, which is going to take place inside the mouth, mixing of food with saliva by the tongue, churning of food in the stomach, and segmentation, which will take place mostly in the small intestine. Segmentation is rhythmic local constrictions of the small intestine's mostly circular layer muscles. Segmentation mixes food with digestive juices and makes absorption more efficient by repeatedly moving different parts of the food mass over the intestinal wall. This process, it basically moves food forward then backward. So here you can see that. Now when this food moves forward and backwards, this causes the food to start to mix. And you have slow food propulsion occurring. Next, then we have what we call digestion. Now, when we talk digestion, digestion involves a series of catabolic steps. When we talk catabolic steps are metabolic steps, if you recall, that break things down. So, digestion involves a series of catabolic steps in which enzymes secreted into the lumen of the alimentary canal break down complex food molecules to their chemical building blocks. So that's going to be digestion. Absorption, then we have next. Absorption is the passage of digested end products, vitamins, minerals, water, whatever it may be there, moving from the lumen of the GI tract, lumen of the GI tract, through the mucosal cells. Movement through the mucosal cells is going to happen thanks to active and or maybe passive transport. And we'll check all that out towards the end. And the movement then into the blood or into the lymph. Right? Because when we talk about lymph, which category of foodstuff is going to make its way there compared to directly into the bloodstream? Right? Lipids. Lipids. Next then is defecation. Defecation, the sixth process, it eliminates indigestible substances from the body via the anus in the form of feces. So let's move through the functional anatomy of the digestive system. Now, when we look at the digestive processes from the mouth down to the esophagus, we'll see the mouth, it ingests, it begins mechanical breakdown, right? Begins mechanical digestion by chewing. It initiates propulsion by deglutition, the scientific term for swallowing. The mouth also starts the chemical breakdown, the chemical digestion of, we can see, thanks to salivary amylase, polysaccharides. It breaks down starches and sugars. Lingual lipase will help break down lipids in a very minute quantity again. Nonetheless, it is occurring. So except for a few drugs that are absorbed through the oral mucosa, such as nitroglycerin, essentially no absorption is going to occur inside the mouth. The pharynx and the esophagus, they'll serve as conduits. They'll serve as conduits to pass food from the mouth to the stomach by swallowing and food propulsion. Next thing we have mastication. Mastication. So when we talk mastication, we're talking the scientific term for basically chewing. So when we talk mastication or chewing, here we're going to be talking about how food molecules are food molecules are going to be mechanically broken down. So when we talk foods mechanical breakdown is going to begin with mastication as food enters the mouth. The cheeks and closed lips hold food between the teeth. The tongue mixes food with saliva to soften it. And then the teeth cut and grind solid foods into smaller pieces, creating a bolus. Now, chewing is voluntary and reflexive. Chewing is partly voluntary and partly reflexive. The stretch receptors, when they get stretched because food, this is going to cause the muscles then to contract. And when those muscles contract, this you see becomes a reflexive response. Deglutition then, next, swallowing, has two major phases. We have a buccal and the pharyngeoesophageal phase. Now, swallowing is going to involve, you can see the tongue, the soft palate, the pharynx, and the esophagus. It requires coordination of 22 muscle groups. Now, the buccal phase occurs in the mouth and is voluntary. Now, in the buccal phase, the upper esophageal sphincter is contracted. So here we could see the upper esophageal sphincter is contracted. The tongue presses against the hard palate, forcing the food bolus into the oral pharynx. Then we move into the pharyngeal esophageal phase. Here you can also see, now what's going to happen is this uvula and the soft palate are going to rise reflexively to help block off the entrance up into the nasopharynx. At the same time, the larynx is going to rise to help block off, and that epiglottis is also going to help block off the entrance into the larynx. And then this upper esophageal sphincter will relax, allowing this food bolus to eventually make its way down into here. So here we could see now, in this pharyngeoesophageal phase of swallowing, basically this is going to be controlled by the swallowing center, which is located in the brain stem, the medulla and the lower pons. Now, once food enters the pharynx, respiration is momentarily inhibited. And all routes, except for the one that leads to the digestive tract, are blocked off. The tongue blocks off the mouth. The soft palate, you can see, rises to close off the nasopharynx. The larynx, I told you, rises so that the epiglottis covers its opening into the respiratory passageways. And then this upper esophageal sphincter relaxes. Wave-like peristaltic contractions create pressure waves that are going to propel food through the pharynx to the esophagus, which you see here, here, and then here you can see the lower esophageal sphincter, the gastroesophageal sphincter is closed, and then it will also relax, allowing that food bolus to make its way into then the stomach. So here we could see this upper esophageal sphincter. If it doesn't open properly, there's a situation when you move to the 6th, 7th, and 8th decades of life that doesn't start to work properly, and that causes this food to then start accumulating within this region and creates a little pouch right in this area here. And you guys will learn more about that as you move through your pathologies, allowing then this food bolus to not fully make its way through, causing some to get stuck in there, creating then halitosis in the patient as well. So that'll be one sign that you should be able to pick up, along with maybe the little pouch that gets created there. So then here you could see the food bolus will make its way down into the stomach. Just before the peristaltic wave reaches the end of the esophagus, this gastroesophageal sphincter relaxes to allow food to enter the stomach. Now, after food's entry, the sphincter closes, preventing regurgitation. Now coming back here, if we talk or if we inhale while swallowing, this causes food to enter the respiratory passageways, and that triggers the cough reflex to help expel the food. Next, then we have the stomach. When we talk about the stomach, we can see here so when we talk about the stomach we could see is got a few different parts to it. Now, first in the stomach, you could see the stomach is going to be found in the upper left quadrant. And when you talk about its function, it's basically a temporary storage tank. What it does, it also is involved with a little bit of chemical digestion. It does chemical digestion of the bolus, converts it to chyme. Now, when you talk about the stomach has a few parts to it. First, it's got a cardia, a cardial part, and that cardia and the cardial part are going to be found surrounding basically the cardiac and the cardiac or the cardiac. Here, let me just go right here. Is going to be found as the initial region. It's the area that's surrounding basically the area where the esophagus enters at. So it's the area surrounding the initial segment of the stomach where the esophagus enters the stomach at. That's the cardia. And then here you got the fundus, the dome-shaped region. It's tucked just beneath the diaphragm. You've probably heard of diaphragmatic hernias where the stomach, this fundus, penetrates through. So hernia is where something penetrates through, and hernia is usually with GI components, right? Inguinal, femoral. Here you could see diaphragmatic. Then we can have happen there. Then the fundus will lead us to the body. The body is the mid portion, and then this leads us to the pyloric region, the last segment. Then the pyloric region. So the pyloric part we've got there. So here you can see all the main parts. Okay, here we have the pyloric valve. We have the upper esophageal valve or the gastroesophageal valve up in here. Right, that valve doesn't work properly. That leads to food regurgitating and making its way up into the esophagus. Okay, here there's a condition and it's a genetic predisposition there. First, male-born child to the female, it usually develops here what we call hypertrophy of the pyloric valve, hypertrophic pyloric stenosis, it's also known as. And that usually appears in the first months of life. And mom, dad come in complaining of the baby having projectile vomiting. Doctor will come in, palpate, feel, and do some studies and tests and determine this is what's going on. And they'll come in, if that's the case, they'll come in and surgically remove a piece of the muscle there, and everything goes back to being normal. So next in here we could see we've got the lesser curvature, the greater curvature, and then inside the stomach you can appreciate the longitudinal folds of the mucosa and submucosa, which are called the rugae. Right? In anatomy you were able to cut through the cat's stomach and appreciate the rugae inside. And we find lots of interesting things inside of there, and they have to usually move these components over to the side, and then they can identify the rugae. So next then let's move down and let's talk then about the microscopic anatomy here. So when we talk microscopic anatomy, so here we could move to this image of the stomach there, another image of the stomach there. Okay, so now when we move into the microscopic anatomy, we're going to be able to appreciate four tunics here, four layers basically. We're going to see the stomach has deep gastric pits, and these gastric pits are going to lead into tubular gastric glands. And these glands are going to be important because these glands are going to be responsible for secreting stomach secretion that we call gastric juice. Gastric juice is going to be important for, we said, some of this chemical digestion that's going to take place. And converting that food into then this basically chyme, that food bolus into chyme. Now, when we go through and we talk about glands, let's look at the types of gland cells inside this gland. So here we could see we've got the mucosa, and then beneath the mucosa we've got submucosa, muscularis, and then the serosa. So what we're going to do is we're going to appreciate the mucosa. Right inside of here is where we could appreciate first the gastric pits, the openings that lead then to the glands. Let's magnify that region there, the mucosa, and this is what we're seeing here. So let's magnify then these glands, the more bottom inferior aspect of the glands, and that's what we're seeing there. Let's magnify that as well. So here is what we're seeing. Now, first, right off the bat, we'll move back. You can appreciate here mucus neck cells. These mucus neck cells are found, you can see, more abundantly in quantity towards the superior aspect of the glands. These mucus neck cells produce a thin, acidic mucus. Also here we can appreciate amongst those mucus neck cells are parietal cells. So here you can see those parietal cells, but here we can appreciate those parietal cells then in greater detail. This parietal cell we see here is going to be responsible for secreting hydrochloric acid and intrinsic factor. Parietal cells, when viewed in detail, as we can see here, have three prongs. They have three prongs that have dense microvilli. And what it does, it provides a huge surface area to secrete hydrogen ions and chloride ions into the stomach lumen. Hydrochloric acid makes the stomach contents really acidic. And that's a condition that's going to be necessary for activation of our protein digesting enzyme that is called pepsin. Now, the acidity also helps digest food by denaturing proteins and by breaking down cell walls of plant foods. So a couple of advantages there. Intrinsic factor is required for vitamin B12 absorption in the small intestine. And that'll take place in the terminal ileum of the small intestine. Next, we can appreciate here chief cells. Chief cells, they produce pepsinogen. Pepsinogen is the inactive form of pepsin. Also secrete lipases. They also secrete lipases, which are fat digesting enzymes. And they're going to account for about 15% of overall lipolysis. So again, it's a minute amount. We also have here enteroendocrine cells. Enteroendocrine cells are located in the intestine and in the pancreas also. Enteroendocrine cells release gastrin. They release histamine, endorphins, serotonin, cholecystokinin, and somatostatin, which are hormones or paracrines that play a role in regulating stomach secretions and motility. Gastrin, we'll see, also increases hydrochloric acid secretion by parietal cells in the stomach, also increases the motility of the stomach. So very important hormone there, gastrin. We also have a mucosal barrier inside of this stomach that I'd like you to know about. And when we talk about this mucosal barrier is present because the stomach is exposed to some very harsh conditions. First, we'll see those protein digesting enzymes and acid can damage and digest the stomach. So in order to protect that stomach, there's three factors that create this barrier I'd like you to know about. Number one, we have a thick coating of bicarbonate-rich mucus. Number two, the epithelial cells of the mucosa are joined by tight junctions. So what this does, it prevents the juice from seeping underneath the tissue and allowing it to maintain polarity. Third factor here is that damaged epithelial mucosal cells are shed and quickly replaced by stem cells. They're replaced about every 3 to 6 days. So moving back then, here we could see we talked glands are going to be found in the fundus and the body. They produce most of the gastric juice. And the parietal cell is going to be responsible for secreting hydrochloric acid and intrinsic factor. So not only does the hydrochloric acid denature proteins, it's also going to activate pepsin and break down cell walls and also kill many bacteria. Now, intrinsic factor is going to be required for the absorption of vitamin B12. And we said that's going to happen in the terminal ileum. And then we said we have chief cells releasing pepsinogen, inactive enzyme, and then lipases there as well, and our enteroendocrine cells. So let's move down to the digestive processes now taking place inside the stomach. Now, when we talk about these digestive processes, when we talk about the digestive processes in the stomach, you'll see first physical digestion is going to take place. We have denaturation of proteins by hydrochloric acid that's going to take place. Enzymatic digestion of proteins, we said by pepsin. And also milk protein by, we can see here, we have already spoken of an enzyme that was similar to this, right? This here is renin. Before we saw renin. Renin, a part of the ROS system, renin, angiotensin aldosterone system. So this is renin. Renin is going to be a protein that we find. It's a milk protein, okay? A protein that's going to break down basically milk in infants. So enzymatic digestion of proteins by pepsin and also by renin in infants of milk proteins. Lingual lipase digests some triglycerides before digested as any other protein. So it's going to break down the lipids, all the way until those lipids and that lipase makes its way into the stomach. Then that protein itself, this lipase, is going to get digested, hydrochloric acid there. Stomach is going to deliver chyme then to the small intestine. It'll deliver it then to the stomach, from the stomach to the small intestine. So when we talk about the stomach, it holds ingested food and continues breaking it down after the oral cavity did its job. It will break down the food bolus both physically and chemically. It then delivers chyme, the product of its activity, to the small intestine. Protein digestion begins in the mouth, and it is the only significant type of enzymatic digestion that occurs here. Hydrochloric acid denatures proteins, we mentioned. The most important protein digesting enzyme produced by the gastric mucosa is pepsin. alcohol and aspirin pass easily through the stomach mucosa and into the blood. Not much absorption occurs besides this inside the stomach. The other stomach function essential to life is the secretion of intrinsic factor. Intrinsic factor is required, we said, for the intestinal absorption of vitamin B12, which is needed to produce mature erythrocytes. That's why vitamin B12 is important. If absent, pernicious anemia and abnormal hemoglobin production can result. So vitamin B12 absorption, we said, is going to take place at the terminal ileum. Vitamin B12 can be administered by injections. Individuals can survive with minimal problems even after a total gastrectomy, stomach removal. So we've got all of that right inside of there as well. Now, when we talk about the regulation of gastric secretions, you will see both neural and hormonal mechanisms control gastric secretion. Normally speaking, in one day, the gastric mucosa pours out as much as 3 liters of gastric juice. Gastric juice is an acid brew that is so potent it can dissolve nails. The vagus nerve stimulates the stomach and the secretory activity of all of its glands. And it'll do that via parasympathetic activation, because the sympathetic system depresses secretory activity. Hormonal control is under mostly gastrin. It stimulates secretion of enzymes and hydrochloric acid, and also of some small intestine hormones. Stimuli acting at 3 distinct sites. Those 3 distinct sites include the head, basically where the brain is at, acting on the stomach, and also acting on the small intestine. So stimuli acting at 3 distinct sites can provoke or inhibit gastric secretions. Now, the 3 phases of gastric secretions we can see here very nicely. We have first what we call the cephalic phase, or phase 1, the cephalic phase or the cephalic reflex phase of gastric secretions. This phase occurs before food enters the stomach. Now, this phase is only a few minutes long, and it's triggered by the aroma, by the taste, by the sight, or even by the thought of food. And it gets the stomach ready, basically, for its upcoming digestive chores. So the sight and the thought of food are going to act on the cerebral cortex, and the cerebral cortex then is going to, you could see act on the hypothalamus and the medulla oblongata. If you recall, we've talked about the various functions of the hypothalamus there, especially in anatomy. Then they will act on the vagus nerve, increasing stomach secretion activity. Stomach secretions, or you could say it's activity. Now, the stimulation by taste and smell receptors is going to directly activate the hypothalamus and the medulla, activating the vagus nerve, then again increasing stomach secretory activity. Phase 2 then. Phase 2. Phase 2, or the gastric phase. This is going to occur now once food reaches the stomach. So once food reaches the stomach, local neural and hormonal mechanisms initiate this phase. This phase lasts anywhere from 3 to 4 hours, and it will provide us with about 2/3 of the gastric juice that's going to get released. Some stimuli to get this phase going are going to include the distension of the stomach, the stretching of the stomach, peptides, short chain amino acids, low acidity, and even gastrin. So here you could see stomach distension activates the stomach stretch receptors, which will then activate vasovagal reflexes and local reflexes. Local reflexes will increase stomach secretory activity, while vasovagal reflexes will then act on the medulla, acting on the vagus nerve, and then increasing stomach secretory activity. Food chemicals, right, especially peptides and caffeines, and also rising pH activates chemoreceptors, which activate then G cells, which release gastrin, and gastrin's release into the blood is going to get stomach secretory activity going. Through stomach distension, acetylcholine gets released, and it stimulates output of gastric juice. Gastrin is secreted by partially digested proteins, also by caffeine and rising pH. Gastrin is secreted by partially digested proteins, caffeine, and rising pH levels because of food. So this gets released by the enteroendocrine cells. So now when these enteroendocrine cells are going to release this gastrin's release increases. And when gastrin's secretion increases, this increase releases, you'll see enzymes and hydrochloric acid by the parietal cells. Highly acidic gastric contents inhibit gastrin secretions. And that happens, we'll see in between meals. Proteins in food, they're going to increase the pH by binding hydrogen ions. Increases gastrin and hydrochloric acid, which are needed to digest proteins. Stress, fear, anxiety, or basically anything that triggers sympathetic activation, sympathetic division, inhibits gastric secretion release, and it overrides the parasympathetic nervous system. Hydrochloric acid secreting parietal cells are controlled by 3 chemicals, and these 3 chemicals are going to stimulate basically we'll see hydrochloric acid secreting parietal cells. First, you have acetylcholine. Acetylcholine gets released by parasympathetic nerve fibers. Hydrochloric acid secreting parietal cells are stimulated also by gastrin. Hydrochloric acid secreting parietal cells are also stimulated by histamine. Some antihistamines block histamine receptors of parietal cells and are used to treat ulcers due to increased acidity. Now, we can also appreciate then hydrochloric acid formation. Now, when these parietal cells are stimulated, hydrochloric acid is eventually going to be formed. So when these parietal cells are stimulated, hydrogen ions are going to be actively pumped into the stomach lumen against a concentration gradient by hydrogen ion, potassium, ATPase pumps in exchange for potassium ions that move into the cell. Potassium then cycles back into the lumen via the potassium channels. So let's look at all of this. Here you can see those hydrogen ions making their way out thanks to this hydrogen ion potassium ATPase pump. So we said the potassium is going to move into the cell. Potassium then cycles back into the lumen via potassium channels. Chloride ions you see here are going to follow the hydrogen ions into the lumen. Why are they going to follow the hydrogen ions into the lumen? They're going to follow those hydrogen ions into the lumen to maintain an electrical balance in the stomach. And voila, we've got hydrochloric acid formed, completing the process to help form hydrochloric acid. The chloride ion is obtained from our blood plasma. And the hydrogen ion comes from the breakdown of carbonic acid, which is formed from carbon dioxide and water, thanks to carbonic anhydrase, which occurs within the parietal cell, again forming for us carbonic acid. As the hydrogen ion is pumped from the cell and bicarbonate ions, we can see here start to accumulate. They start to accumulate. Now these bicarbonate ions, they are going to be ejected from the basolateral cell membrane into the capillary blood. What this does, it causes the blood that's draining from the stomach to become more alkaline compared to the blood that is servicing the stomach. So this bicarbonate ion being removed and put into the blood capillary, we call this the alkaline tide. The alkaline tide. Chloride ions come in from that bicarbonate chloride antiporter. It moves them in to the cell in a direction opposite to the bicarbonate. Potassium and chloride move into the lumen. They move into the lumen by membrane channels, thanks to membrane channels. Next, then we have phase 3. Phase 3, or the intestinal phase. I want you to know this phase now has two components. One stimulatory and one inhibitory. The stimulatory aspect is set into motion as partially digested food or chyme fills the initial part of that small intestine or the duodenum. What this does is it stimulates the intestinal mucosal cells to release gastrin, which then stimulates gastric glands to continue secreting. The stimulatory effect is brief. Why? Because when the intestinal wall distends with chyme, when the intestinal wall distends with chyme, that has hydrogen ions in it, that has fats in it, and partially digested proteins in it. What this does, it triggers the inhibitory component. Now, the inhibitory component, what it does is it decreases gastric motility, and it's triggered via the enterogastric reflex, which is a trio of reflexes that are going to do a few different things. Number one, inhibit the nuclei in the medulla. Number two, they'll inhibit local reflexes. And number three, activate sympathetic fibers that are going to cause the pyloric sphincter to tighten and prevent further food entry into the small intestine, right? Overwhelming that small intestine. Also, it decreases gastric secretory activity. So you can think of these as the brakes. These brakes on gastric activity are going to protect the small intestine, and they're going to allow that small intestine to process chyme. These factors also release other intestinal hormones such as secretin, CCK, cholecystokinin, and VIP, vasoactive intestinal peptide. Now, all of them are going to inhibit gastric secretions when the stomach is active. Now, we can see here also we have inhibitory events in relation to the first two phases. First phase, a loss of appetite or depression, leads to inhibition of the cerebral cortex, leads to inhibition or inhibiting, basically lack of stimulatory impulses to the parasympathetic center, not increasing secretory activity. We talked phase 2. If we have excessive acidity, we said, right? Less than 2, which happens in the stomach, this inhibits the G cells. Gastric secretion declines. Emotional stress, activating sympathetic nervous system, which overrides in parasympathetic nervous system controls. So you have to be able to explain all these events inside of this picture as well. So we went through the intestinal phase as well. Let's talk bile. Now, bile is produced by the liver and it is stored in the gallbladder. When we talk about bile, bile is a yellow-green alkaline solution which contains bile salts, bile pigments, cholesterol, triglycerides, phospholipids, and also electrolytes. Now, out of all of these components, only bile salts and phospholipids aid the digestive process. Some bile salts are derived from cholesterol. Now, their role is to emulsify fats or to break them down into smaller pieces, right? That's what emulsify means, to break them down into smaller pieces so that way we can facilitate fat and cholesterol absorption. The chief bile pigment is bilirubin. Bilirubin is a waste product of the heme of hemoglobin. One of heme's or bilirubin's breakdown products is stercobilin. Stercobilin gives feces its brown color. And in the absence of bile, feces are gray, white in color, and they will have fat because fats are digested or absorbed. But in this case, without the bile, right, in the absence of bile, feces are going to be, we said, a gray or white color because fat is not absorbed or digested, and it's going to be found here. Stercobilin. Stercobilin gives feces its brown color, and in the absence of bile, feces are gray-white and have fat because no fat is digested or absorbed.